So, thymomas are actually a group of uh, tumors which comprise of almost 20% of all the mediastinal tumors and around 50% of all anterior compartment tumors and 90% of all thymic tumors are actually thymoma. And they originate from epithelial thymic cells and obtain and contains epithelial, lymphocytic, and mixed populations. 40 to 60 years old, they are female more than male. There are slow growing tumors with a huge malignant potential. The malignant potential basically consists of local invasion, systemic metastasis, and there might not be overt cytological features of malignancy during the histopathology. So almost 50% of the cases are asymptomatic and are usually diagnosed on chest X-ray or autopsy. However, around 30% present with pressure or invasion systems like SVC syndrome, cough, chest pain, dysphonia, dysphagia, and nearly 20 to 70% of thymomas are associated with autoimmune disorders like myasthenia gravis, pure red blood cell anemia, and hypogammaglobulinemia. And so these 10 to 15% of myasthenia gravis patients can also have associated thymomas. However, almost 30 to 50% of the patients with thymomas have myasthenia gravis. Pure red cell aplasia is associated with thymomas in 30 to 50% of the patients. Conversely, only 5% of the patients with thymoma have pure red blood cell aplasia. Hypogammaglobulinemia is also associated with thymomas in 10% of the cases. However, only 5 to 10% of the thymoma patients present with hypogammaglobulinemia. So, according to the WHO classification, we have currently the most accepted classification is the WHO classification, which has converted it into type A, type AB, B1, B2, B3, and C. Whereas the type A and AB are considered as completely and purely benign with almost 100% survival. Type B1, B2, B3, and C are considered to have significant malignant potential, with type B3 and C being the most aggressive of them, with almost 35 and 28% 10-year survival. On evaluation for the myasthenia gravis patients, we always do a CCT and we evaluate for myasthenia gravis. Even if the patient is unsymptomatic, any patient coming with thymoma has to be evaluated for myasthenia gravis using RNST, the repetitive nerve stimulation test, the acetylcholine cholinesterase receptor antibody test, and we should anticipate any post-operative respiratory muscle weakness if possible. So usually this is a multidisciplinary effort with the team of neurology and the team of surgical oncology working together to get the patient fit for surgery. So currently thymectomy, the indicated with all patients with thymoma. However, in patients of myasthenia gravis without thymoma, the decision is usually based on clinical correlation according to age, sex, severity, and response to medication. A strict contraindication to thymoma, that is thymectomy, is the neonatal type of myasthenia gravis, which is usually treated with medication. The second caution has to be also be exercised for juvenile myasthenia gravis and should be attempted only if there are severe symptoms and there is a lack of response to therapy. So we have got various techniques of thymectomy, which consists of open thymectomy. There is the video assisted thymectomy and the robotic thymectomy. Open technique is a time-tested technique which consists of either transcervical or transsternal technique, whereas VATS and robotics are now the minimally invasive alternatives which now we have. The open techniques consist of transcervical and the transsternal techniques. So for the thymectomy, by definition, includes all the removal of the thymus along with all the tissues anterior to the pericardium from thoracic inlet to the diaphragm lying between the right and left phrenic nerves. So I would like to tell you an index case of this thymectomy patient. This was a 32-year-old male serving soldier in the Indian Army. He had no comorbidities. He was asymptomatic, and on the routine chest X-ray, he was discovered to have a mediastinal widening. So we performed the CCT, which showed 3 into 4 centimeter mass in the anterior mediastinum, and not infiltrating into the anterior mediastinum and not infiltrating the surrounding structures. The RNST and the acetylcholinesterase antibodies were normal. So he underwent a left thoracoscopic VATS thymectomy. So this is the CCT, as you can see. This is the mass which you can see here. This is the coronal section. Is the sagittal section, suggesting the mass here overlying the aorta, and the heart just overlying the bronchus. So the trachea is here. This is the aorta, and this is the mass above, as you can see. This is the ascending aorta, just going towards the arch of aorta. So we use general anesthesia. A single lumen tube was used by us, and we use CO2 insufflation to bring the lung down, thus avoiding the major comorbidity of a single lung ventilation. We rarely use single lung ventilation for thymectomy now. We almost always use single lung ventilation using CO2 insufflation, and we use the 10 millimeter 30-degree ports. So this is the position of the ports. We use a right or left lateral position according to the VATS thymectomy, which we are going to do with most of the patients which have to be approached from the right side. However, if the lesion is predominantly on the left side, we will use a left lateral approach. The 3 ports which are marked here with 2 working ports at the 5 ports in the 4th and 7th intercostal space in the anterior axillary line, and 10 millimeter port in the 5th intercostal space posterior axillary line. An additional accessory port, if required, we place it at the 9th intercostal space in the anterior axillary line. So I would like to demonstrate the video. So as you can see here, I will pause the video once. This is the thymoma. This you can here see is the heart with the pericardium, and these are dilated vessels over the pericardium which are supplying this thymoma. So we enter it, we use a energy device. Usually the energy device is the harmonic. So this is the harmonic which is being used. So we start with the lower pole mobilization. So if you can see here, the white line which is going around is the phrenic nerve of the left side. So we release the lower pole, and this is the pleural, the mediastinal pleura, which is being dissected to free the thymoma. So after the lower pole, we go to the superior pole, and we slowly and slowly dissect it free from the thing. The lower pole is lifted from the pericardium. All these fat tissues have to be taken along with the thymoma. So this you can see here is the phrenic nerve. This phrenic nerve is going to supply the diaphragm. So we have to be very careful around this area. We remain close to the capsule. We are trying to save this phrenic nerve. So after clearing it, we go towards the upper pole. See, you can see here is the this is the brachiocephalic vein, which is going here. It is supplying the upper pole of the superior horns, as we call it in thymoma. It is being separated. So using the energy device, we are able to gain the mobility. Again, the lower pole has to be freed completely. So this is the pericardium. The surgery proceeds from the inferior towards the superior. We have mobilized the superior horns. We have mobilized the inferior horns. Now we continue towards the superior part. So the upper pole has to be taken very carefully. Lots of bleeding can occur in this region because this is a direct branch of the brachiocephalic vein, which you can see here, lying on the roof. Important to give good counter tractions and tractions to clear up the plane. So the final attachments are being removed, the left-sided phrenic nerve being preserved. Taking the final clips. As you can see, this is all the thymoma poles. This is the superior pole, the superior thymic veins which have been ligated. This is it. And so the specimen is in completely removed. This is the specimen which is being removed in a bag. The staging which is followed is usually the Masaoka staging, which is the most accepted and widely used staging system for the thymomas. Stage 1 and 2 comprise of well-encapsulated tumor without any capsular invasion, and stage 3 comprises of tumors infiltrating to the adjacent structure, and stage 4 is disseminated disease. So what we did is we retrospectively analyzed around 24 VAT thymectomy patients which underwent from 2013 to 2018. All the patients had myasthenia gravis, and the mean size of the tumor was 4.08. We were very selective in doing which patients we should go with video-assisted thymectomy because more than 4 centimeters and 5 centimeters always meant that it will be a very dicey situation for a thoracoscopic surgery. And the exclusion criteria was the infiltration of the surrounding structures. So almost 75% of the patients were male and 63 belonged to the 20 to 40 years of age. And only 8% of the patients belonged to less than 20 years of age. So we found that when we compared our VATS finding with open thymectomy, we were able to find that almost the mean operative time was 164 minutes as compared to open, which was 147 minutes. I think so this goes down as our experience increased. The blood loss in VATS was extremely low as compared to the open approach, which was just at 178 ml as compared to 225 ml. The mean chest tube duration was also very low. That was only 3.2 days as compared to around 9.2 days in the open transternal approach. And the mean length of the ICU stay was almost half of that required for the open transternal approach, which was a major source of saving the money for the patient. Duration of stay in the hospital was also very low, just 3 days as compared to almost 9 days for the transternal approach. And the VAS pain scale was only 3.5 as compared to almost 5 or 6 for the open transternal approach. Post-operative complications like cardiac complications and pulmonary complications were also very low, but the complications were similar for both the VATS and the open. However, if we consider late sequel of sternotomy wound, which can cause a dehiscence and everything, the complication rate might reach to almost 15% for the transternal approach. So nosocomial pneumonia and phrenic palsy was just one patient which we had. Other than that, no patient had to be re-intubated due to the myasthenia crisis because of our courtesy to our excellent support from the neurology colleagues. No pneumothorax, chylothorax was encountered, and we had no perioperative mortality. So we had the WHO type B1 was the most common histopathology which we observed, and all patients were Masaoka stage 1, and R0 resection was achieved for all patients. and the mean tumor size, which was on final histopathology, was around 42 millimeters. It was 4.2 centimeters. So, because of our careful selection, we did not find any type B3 or C, type C in our series. So almost 50% of the patients had complete remission of myasthenia gravis, which is in accordance with the worldwide literature of open transsternal sternotomy. We did not find any patient who were earlier on steroids requiring steroids post-operatively, and only 2 patients remained on a 2-drug regime post-thymectomy out of 5, which with this the discussion regarding this is that from the 1970, thymectomy has been being performed by the surgeons, which includes von Haber, Blalock, Carlsens, and the current gold standard is transsternal. And in the 90s, VATS thymectomy was introduced. Currently, there are two large meta-analyses which has been done by Yang et al. And Fridet et al. All of them have suggested that the main advantages are the reduced per-operative blood loss, the reduced pain scores, the length of stay, and overall complications, while delivering an equivalent oncological and neurological outcomes. So the key surgical points from my side is that the experience from the VATS thymectomy is increasing in myasthenia gravis. The completeness of the thymectomy is extremely crucial, and we have to look for accessory horns other than the superior horn, and especially under that brachiocephalic or the innominate vein. And routine identification of left and the right phrenic nerves is very important for safe surgery. The superior and inferior horns are sequentially mobilized and used for traction to avoid any breaching of tumor capsule. Extra 5 millimeter port to increase the exposure, especially for the large hyperplastic glands and patients, especially obese patients with an abundant perithymic fat. In these patients, the extra 5 port will be of a lot of help, and the semi-supine position allows for a quick conversion to sternotomy if it is needed. So it is a safe and minimally morbid operation, decreases the amount of medication stay. We have got reduced post-operative complications, whereas the pain and requirement of analgesia is the same, and the operative time is actually reduced or almost similar. Thank you so much.